The patient is 68 years old with hypertension for 30 years, diabetes for 1 year, and smoking for 54 years. His chief complaint is paroxysmal chest pain for 10 years. His ejection fraction is 65%. The following is laboratory data. You can see glucose and plasma lipid level is abnormal. The electrocardiogram shows the left axis deviation. Now, 1 year ago, the patient performed angiography at a local hospital. We can see left coronary artery is normal, with collateral flow from RCX and septal to distal of RCA. Now the RCA is a total occlusion. 1 year ago, the patient at a local hospital performed angiography. The doctor attempted to recanalize the RCA but failed. Next, we'll invite Dr. Professor Li to introduce more detail about this patient.
Hello, everyone. So just now, Dr. Jing already introduced the baseline information of this patient. So as we know, this patient is RCA proximal middle portion, should be middle portion total occlusion, and with a bump stamp, and with side branch at the ostium of the proximal cap. And for this kind of chip PCI case, certainly we will do a CT angiography first and use the intelligent visualization system. We need to make sure the distribution of the CTO lesion. And this is a RCA CTO. We can see the yellow one should be the true lumen of the RCA, and the brown one should be the occluded segment. Can you see the Andrew? Okay.
Yes.
Okay. So from the Andrew, we can see really still a proximal middle portion, proximal middle portion occlusion, and there is a large side branch, and we couldn't see the nose stamp. And then this is a left coronary artery angiogram. We use BR30 guiding, and one tips and tricks to put workhorse wire to the circ to make the guiding backup support, because we also could see the left main is very short.
Yeah.
So this is the Andrew. We can see several septal collector channel from the LED. Maybe the first diagonal branch and the septal branch and the second septal branch. And this is a bilateral angiogram. The collateral branch is good, should be the first choice, because the direction of the retrograde wire could be directed to the distal cap, and should be the optimal route. But we can see the collateral channel very tortuous.
Okay, so we can see that Professor Li just put the IVUS catheter in the proximal side branch of the RCA and made a manual investment to see the joint site of the main vessel RCA to the side branch. So from this image, we can see that from the 1 to 3 o'clock direction, we can see that there is a very big vessel joining into the side branch. This is the occluded main vessel of RCA. So from the angiography, we can see the imaging of the black spot on the imaging catheter. And also on the IVUS, we can see the exactly spot where the main vessel is joining inside. And
so I will, advance a little bit below that branch to increase backup support.
Yes.
Okay, a little bit deep seating the guiding. We can see, okay, the passive and the active
support,
support increase. Okay, and then next I will try to advance a little bit the cochlear microcatheter, because the occluded segment is relatively
It's
tortuous.
tortuous and pretty long.
I'd like to. Okay, RU, please. A little bit further the right. RC test a little bit. Okay, Andrew, not very forceful. Okay, okay. RU, premium, RU premium. Yeah, RU premium. So, no very good collateral channel.
Yes. So after 1 year, we can see that the mid part of the occluded segment has been ruined. There is no clear landing zone. So from the RCA angiography. So after 1 year, we can see the vessel situation get worse. The insertion of a guide wire into the set branch is of key importance. Just like in this case that we put a wire and also a 2.0 balloon in the set branch, which can act as a marker of the set branch or region, and also can increase the active support of the whole system. Sometimes the balloon inflation in the set branch can also offer active support for the whole system.
When we de-escalation the wire, what's your opinion? Which kind of wire should be the first choice?
I think this is a personal choice. I'm not quite sure whether there is the correct answer, but for me, I think that I prefer the Gaia family wire. I think it's relatively a good manipulation, and also it's not that kind of dangerous. Since we make a good progress of the first step, we entered into the vessel architecture. I think we can try something that is not so safe.
So we will advance a little bit to the cochlear. Okay, advance a little bit.
Yes, we made some progress. From angiography, we may easily think that the proximal entry point is the connection part of the set branch and the main branch. However, from the FC image from the set branch, we identified the true entry point of the antegrade spot, which is not the connection part of the set branch and the main vessel. So intravascular imaging is of key importance in the CTO procedure, I think. Now that we can see that Professor Lee has changed the antegrade wire to attempt to go from the antegrade, because we just tried the retrograde, but the microcaster has some resistance in passing through the septal collateral.
Maybe in the segment should be retorters. But make sure if the wire V is right or not.
The entry point is fine, but it's hard to say whether yes.
Here should be a very retorter segment. Sometimes in order to make the wire in the vessel structure, so okay, knuckle sometimes also could be tried. Okay. Because I use UXT wire and the wire, okay, as we know, the knuckle, the tip is relatively small.
Yes, make a small curve.
Okay.
And the hydrophilic coating is, how to say, friendly to the knuckle movement. Yes, this is of key importance because we can see that after you perform the knuckle techniques to cause some subintimal tracking, that it is of key importance to avoid antegrade injection. So although there is some tortuosity, so maybe we can try to use some small balloon to try to, dilate the septal, curve a little bit to try to help the microcaster to pass through. Maybe this is one of the choice, but this is a little bit risk because of the septal damage may cause some contrast residue and some little bit perforation. But this is I think techniques that we can try from the retrograde. Traverse cast fibrous cap is relatively softer compared to the antegrade fibrous cap.
Should be in the subintimal space.
Mm-hmm.
In a look like a spiral-like.
Mm-hmm.
Okay, here must be very careful. Okay, and you? Oh,
okay, we reached the distal bifurcation site.
Okay.
Are we in the the PLV side branch or something?
Okay, if the work would come
like
to any that branch is okay. Test a little bit.
Okay, sure. I think it's okay. Professor Lee.
Okay, I think.
Oh yes, I think that we go into the bifurcation of the PLV.
The feeling. We draw.
Yes, we draw.
You see if there is continuous.
Yes, make the vacuum
flow back. We can see blood flow back. If no blood flow back, we do not do the supersedactive.
Okay.
Even we could see the blood flow back. We also don't do forceful injection. Just test a little bit first. Okay.
Okay. Yes.
I think this is good.
Okay. Yes.
Okay. CNYR, please. Okay. I think we're ready.
I think the key information is that Professor is a high volume, very experienced CTO performer, and the hybrid strategy is of great importance. We can see that we changed from antegrade to retrograde, and then we come back to antegrade. I think that theory of hybrid strategy is very important because we do not only focus or stay on one strategy to focus on it. Like Professor Li said, we perform the antegrade, parallel techniques using many wires to puncture with blind puncture. This is of high risk of potential hematomas and damage to the vessel. I think this is a good demonstration of a hybrid theory and strategy of performing a very extremely difficult CTO case. But I think we will make some progress.
Okay, 1.5 balloon again.
Yes. We just use 1.0 balloon. I think it's not enough because the outer diameter of the Elvis caster is
0. Okay. Wow.
Okay, so I think, thank you. This is a great accomplishment. So Professor Lee, we are still online.
Okay.
Dr. Mehta want to see us finish this case. I think this is a great accomplishment. Thank you. And we are still working on the case. So as you can see that after the wire goes into the distal lumen, we're using a relatively small balloon to dilate the relatively proximal and mid part of the CTO segment to help us the imaging catheter to pass through. One thing is that to check the entry point and also the plaque distribution, the situation, and also the subintimal tracking situation of the CTO segment to push the macrocatheter beneath as a proximal part of the perforation and using the macrocatheter to transduce the absorbable structures. We cut it into small pieces of the absorbable structures, something like 0.5 centimeter or 1 centimeter something, to using the macrocatheter to push the absorbable structures to the perforation site. One thing is that we can select how many segments of the absorbable structures we goes into the occluded segment. The second thing is that we know the structures is bioabsorbable. So after the follow-up, it can be fully absorbable by the human structure, do not leave anything else that causes distal problems. So I think this is a good technique. Okay, I think Professor Lee has just, managed to put the second antegrade parallel to the distal part of RCA. Okay, we are trying to modify the distal part of the CTO segment. This is a 2.0 balloon, right? 2.0, yes, 2.0 by 20. This is a 2.0 by 20 emerge balloon. We're trying to modify the distal cap using 2.0 balloon. Actually, there is a very interesting, result acquired from the previous manuscript that the sub-advantage stenting VS compared to that of true-to-true lumen stenting, there is no, obvious difference in cardiac death, target lesion revascularization, and myocardial infarction during the follow-up in the CTO cases. So we do not have to worry, too much for the subintimal tracking, or we just mentioned, within the vessel architecture theory. So there is no obvious difference compared to the cardiac death, target lesion revascularization, and also myocardial infarction compared to the true strategies. Iwas, please, yes. Yes, we just noticed that Iwas cannot pass, but Sasuke passed through the occluded segment very smoothly. We have leg cross NSE, just like this one we are using. And also we have the other ones like the, for example, angioscope, and we have the chocolate balloon, etc. We have some scoring element on the surface of the balloon with some neon thread on the surface of the balloon. After the, we can see the dilation. This kind of scoring element can perform some cutting techniques to the plugs. It can press and make some flags, some cuttings of the plug to help us to make better dilation.
I think you are right. Yeah.
Yes, we go through.
That is what I worry about. Would be rotation of the different wires. Okay, I think the Iwas already go.
Okay, let's check the Iwas.
Okay.
Okay, now we have goes into the distal lumen of the RCA, and now there is no doubt. Let's make a pullback. Okay, let's make a pullback. Okay, now from here we can see that there is no severe damage to the vessel. Here is within the lumen, and also okay, I think that from hematoma, yes, big hematoma from the lateral side. Here is a subintimal tracking space. Here is a whole segment is a subintimal tracking, but it's within the vessel architecture. Okay, we are still in the subintimal space. We can see the compressed relatively intima on the side of the vessel. Due to the scoring balloon dilation, we can see we have a very good instant lumen gain. Yes, and also there is another very important information is that we can see the hematoma has been, proceed engaged into this distal bifurcation a little bit. So it didn't resist it only within the bifurcation proximal segment. The hematoma has been engaged into the distal small branch a little bit. So I do not think that this is a good sign, because after further balloon dilation or stenting, this hematoma may engage into the even more distal part. Okay, we are performing the second time using the dual lumen catheter to try to go into the PDA side branch.
Here, a little bit difficult.
Yes.
I think, as we know, here there is a angle here. Epicaudal, please.
Epicaudal, yes. I think this is a pretty tough situation because it is a CTO's case, and also it's a bifurcation situation. So, yes, this is a.
Okay, I think I need a more
stiffer, maybe.
Yeah.